hypertension that is also important, for which we have advances and also some controversies. It's chronic thromboembolic pulmonary hypertension, and there's probably no better speaker than Irene Lang from Vienna to present comments and proposals.
Thank you, Jean-Luc. Olivier, dear audience, I have the honor to provide my commentations and proposals on how CTEPH stands in the current guidelines, and I thought I'm simple, and I will speak about 4 issues. One is on diagnosis, one is on the disease concepts, one is on the treatment, particularly highlighting balloon pulmonary angioplasty. So the clinical classification places CTEPH in group 4, and as you see here, among all the other conditions that cause pulmonary artery obstructions, CTEPH is the leading condition here. Recent discussions and publications have been circling on the thromboembolic origin of CTEPH, which you see here, a thrombectomy specimen and an endarterectomy specimen of patients with acute PE versus the chronic condition with very different histological and macroscopic appearance. And this publication that I've been leading based on the European registry has illustrated that acute VTE is a condition that is predisposing to CTEPH, and numerous studies that are listed here have been focusing on this very important question whether acute PE begets chronic thromboembolic pulmonary hypertension. But as you can see very, very quickly, the cumulative incidences are 100-fold apart, and that should raise some concerns on the hypothesis, I would think, which has been quite nicely addressed in a single publication where the CT signs of CTEPH were reported in all of the cases of CTEPH after an acute PE, which brings me back to the message that I would like to give you here, and that is we have to consider that the reported history of acute PE in over 75% of CTEPH cases may be an overestimation. And while we do think that CTEPH is a thromboembolic condition, it is not correct to rule out CTEPH on the basis of an absence of a history of VTE. So originally, Kenneth Moser did connect somehow VTE and CTEPH, but his view was that 60% of all CTEPH cases had never presented as acute PE. In recent years, it was turned around, and people were using thromboembolic history as a mandate for the diagnosis. So I want to bring you back now that if you don't see that, it's not ruled out. That's my first comment. My second thought is on the diagnostic algorithm, as shown here. There is echo, very, very important, and then the ventilation perfusion scan is the next level of diagnostic evidence. So in echo, there is a mention in the guidelines that you consider risk factors. But I think we have to bring in more of the knowledge of the risk factors, and this is an original publication from several groups that have listed ventricular atrial shunt, maybe not so common, but splenectomy is not so rare. And then all the other conditions like thyroid replacement, antiphospholipid antibodies, cancer survival, inflammatory bowel disease, the blood groups, maybe the factor VIII will gain more relevance after the GWAS analysis of the Cambridge group. So I think we have to integrate that much more in our diagnosis and bring it in right here before or after the echo, similar to acute PE, and perform a likelihood assessment in the diagnostic pathway from the symptomatic patient to the specific diagnosis of PH. Furthermore, as shown here after the VQ scan, which I don't want to discuss here, the other imaging, including pulmonary angiography, is listed here with a plus minus. My view on this is, and I think people will find out, this is an example of a digital subtraction angiography that doesn't look very abnormal to some of you. But if you do a more selective injection, as shown here, with a catheter deeply inserted in this segment, you do see here there is blockage at this level, which is still major vessel level, right? It's a small artery, but it's still the major vessel level. And after a dilatation with a balloon right here, you see that the vessel goes out much further. So I would like to highlight the power of direct angiography in this condition, which is sometimes located at the periphery, and brought to the attention of the physician and hopefully also to the attention of the surgeons, who commonly do not like to look at these pictures in so much detail. So my proposal for the diagnosis is to integrate clinical likelihood and to maybe search for more factors that may be associated with CTEPH. And I'm highlighting here the example of splenectomy as a definitive cause for CTEPH, and we can discuss. In the diagnostic workup for CTEPH, I would think an invasive angiogram should be mandatory and not a plus minus. And I would also emphasize that in doubt, selective angiography with direct injection should be performed regardless of the treatment that it entails. Treatment options are listed here. We've today pulmonary endarterectomy as the gold standard. We have medical with the CHEST 1 and CHEST 2 trials providing statistically significant evidence for the action of riociguat in non-operable CTEPH. And there is angioplasty, which originally came from the Feinstein and Landsberg group and was then optimized in the Japanese group and now has returned back to Europe. And you do see that there is pros and cons with all three modalities, but the vision is to combine, if needed, for a single patient and to find out in the next future how they will be combining, how medical will bridge to PA or how angioplasty may combine with medical. And I think there's a wide field of possible studies that I'm really looking forward to, and I think they will really improve the outcome for our patients. In the treatment algorithm, you may know that the risk-benefit ratio has been brought in the last guidelines, and I think it's of germane importance and should actually be explored much more. This is an example of a typical patient, and if one is doing surgery in one of those frail patients, several risk scores are available, and I think we should also incorporate those in the assessment of operability, definitely. And as I mentioned already, frailty, which is composed of the grip strength, the gait speed, the average day, the instrumental daily living assessment, cognitive, and the BMI, and this is classified on 3 levels, and there is a 5-meter walk test incorporated in that, which I think is not competing with the 6-minute walk test, but some of the patients with chronic thromboembolic pulmonary hypertension are quite old, and we are faced with decisions that are at the same level as decisions for TAVI patients, for example. So the mean age of non-operable in the European registry was 67 years. So we see actually very old patients as well. And based on the work of the CTEPH Association and on the outcome data that have been summarized by Marion Delcroix, there is even more factors that have to be brought in, such as the ones that are highlighted in green are conditions that diminish the risk, which is a history of VTE and preoperative mean pulmonary artery pressure. And there's other factors that worsen the outcome: dialysis, dependent renal failure, any bridging with PAH drugs, need for additional cardiac procedures, the NYH class, of course, history of cancer, increases the risk for death. Increased right atrial pressure, coronary and left heart failure, and chronic obstructive disease. So we have to bring that in as core, I think, to aid in the correct decision-making within the 3 treatment options that we have today. And in addition to that, my group is collecting data on pulmonary artery occlusion waveform, finding that the original observation that has been published in Circulation in 2004 by Nick Kim is valid, is reproducible, and provides another little stone in the pathway to the assessment of the patient. And I will quickly explain to you, this is an occlusion curve from a patient with an upstream resistance of 81, which is considered to be reduced, but still in an area where the study found a good prognostic indication, while this patient on the right side has a flat decay from the occlusion point of the Swan-Ganz balloon to the wedge, and the flat decay correlates in this case to an upstream of 52, which is below this magic threshold that Nick identified in his study of 60%. So this can be done during a right heart cath in an experienced team. It provides another piece of evidence for the status of the vascular bed in patients, and is a prognostic factor, and I would not leave it out. So let me summarize what I just said. I think risk assessment should be performed, should be brought in a very organized fashion. It should include surgical risk. It should include CTEPH disease inherent risk, as shown in the publication. It should also relate to vascular physiology that can be assessed by upstream resistance. The treatment algorithm, of course, brings in targeted medical treatment, and I have mentioned that there will be numerous studies I envision, which are very important. And there is also a mention of the balloon pulmonary angioplasty as a treatment option, and it's given the recommendation to be class of evidence C, which at the time is what it is representing. Yesterday, 12 groups from Europe sat together and brought to presentation their experience with balloon pulmonary angioplasty, and we've put together the data on efficacy represented by the change of mean pulmonary pressure, the change of cardiac output or index, and the change of PVR from baseline in what was reported from these groups. You see there was few that didn't report anything based on small numbers or on other issues. And you do see that today in Europe, I should say yesterday, 556 patients at least underwent balloon pulmonary angioplasty in 2,329 sessions, and that the change in MPAP, including all the learning curve that has to have gone on in the last 2 years, mean PAP was decreased by 23%, cardiac output increased by 17%, and change in PVR by minus 38%. So this seems to be a powerful technique in the hands of these experts. It compares with a real, quite interestingly, but there's of course no direct comparison possible. I just placed the data from the CHEST-1 study here, where PAP was decreased by 9%, cardiac output by 20%, and PVR by 29%. So in no session and no radiation. But I think we will have to test that hypothesis. Is Rio equal? And Professor Simoneau and his group have already set up the RAISE trial that addresses exactly that question, and will change our prioritization of treatment options for patients with CTEPH. And another approach to do this is the International BPA Registry, which is an international registry just recently brought to life, I have to say. It is sponsored by Bayer. It targets 20 sites from Europe, North America, and Japan. It's very similar to the old CTEPH registry, only Japan has come in, of course, which is very important. 500 patients are targeted. the efficacy and safety of BPA will be addressed, also the change of MPAP and PVR from baseline, and there will be, of course, an analysis of the patient selection process, which will be very important. Techniques will be compared, and complications will be defined and monitored. So this is an activity that will change the landscape worldwide. The Japanese group has the vastest experience, and in this complicated slide I will highlight for you the key message, which is complications that have been reported yesterday as anywhere between 1% and 10% of cases depend on the lesion that are addressed by BPA, where the tortuous lesions are the worst lesions, and bringing that all in a more readable texture, I've drawn out here the various lesions that are present in the lungs of CTEPH patients, regardless of operability or non-operability. There is the ring-like lesions, the webs, which is intravascular fibrotic flaps, the subtotal occlusion, the pouch defects, and in the distality, the feared tortuous lesions and the occlusions. And subtotal and tortuous turned out in this large patient group as the most complicated and complication-prone lesions. So we have to bring that in our calculation of what we do with our patients, whether we do BPA or not. So summarizing this, more than 500 patients have undergone BPA in Europe today. BPA is effective. Mean pressure is going down by 23%, PVR by 38%, and cardiac output goes up by 17%. This is the numbers we read yesterday. It's, of course, not controlled. It's simply observational. The complication rates were between 1% and 10% of the cases. A European registry, fortunately, has been sponsored and is underway and much needed. And lesion classification has to enter this procedure, and a risk score, I'm sure, will be internalized by everybody who is doing this. So, as a summary of this, I think the treatment algorithm would be a good window out into universe, and I will show you what I think. I believe that in the pathway of treatment, the imaging will be a very important layer, and the risk assessment. Of course, technical operability is a first assessment, but it's really the imaging that should be here first, and then if the risk is acceptable, BP, pulmonary endarterectomy will be performed. If it's not acceptable, medical treatment, and then is BPA possible? Can we use a BPA risk score? And then BPA will be performed. And then there's a way back to the targeted medical, and lung transplantation is even further out in the algorithm. And of course, there may be a sidetrack to targeted medical, maybe BPA first and then targeted, or the other way around. This is still to be defined, and I'm very, very anxious to know. Thank you.